each part of the system, but on the global system. So we need to have a coordination mechanism. And we are working on that with our telemedicine and citizen platform that can understand better the needs. So the first thing is to coordinate the different hospitals. For that, with the ministry, we have started to define what is the mission of different organizations in the system, which is probably the most difficult thing to do, because you will have to say to this organization, you are a secondary care hospital, you are a tertiary quaternary care hospital, you are a primary care facility. And you will fund these different organizations according to their mission. And you will pay for that. But then you have a political issue, because the deputy of this, the political person of this region don't want to have a small amount of money for their secondary care or primary care organization. They want to have a big hospital to make it. And by the way, here in Quebec, we have already invested $7.5 billion, and we will invest about the same thing to make big hospitals, which is completely anachronistic and not adapted to the needs of the population anymore. But anyway, so the first is a coordination center that will say to the patient, you need to go there, you need to go there, you need to go there. The second thing is we need a quality framework to be sure that when the patient is oriented toward this secondary care hospital, for instance, the level of care is appropriate to the need. Because if it's not the case, the quality of care will be poor. First, for the patient, it's not appropriate, but even for the system, because then you will have complication and need to have more complex care to solve the problem of the level, the secondary care level. So you need first coordination, second a framework of quality of care, which is what we are doing with Accreditation Canada, which is our organism for ensuring that the quality of care throughout the trajectory of care is good. Then you have the third thing, which is if you don't fund the tertiary quaternary care hospitals, you will stop education, research, and innovation. So your system will rapidly decrease in terms of quality and efficiency. So that's a balance that you have to keep when you will fund or not your different hospital, according to the mandate of each of them, and working at the orientation of the patient and ensuring that the quality of care is good. This is what we call sanitary triad and regional and provincial organization of care based on the trajectory of care of patients, which is a huge work, which has not completely begun here in Quebec. Even if the ministry thinks that they have achieved everything, it's not true. We are just in the middle of, and we are changing probably the government soon, and maybe we will come back to other mechanisms. So it's interesting to see what will happen. Karina, if you want to answer.
Yes, thank you, Dr. Boutin. And thank you for sharing some of your challenges that you confronting. We had the opportunity to work in other countries in partnership and be able to support some health reforms.
Can we give some example?
Yes, even if our systems are very different, with the financing, the access, or even the number of doctors or nurses that we can train, or the epidemiology profiles of population, we share the same challenges, which is quality, access, efficiency, as you mentioned, and governance. For for health reforms in other countries, I'm going to give you some example in Kazakhstan, and it's related to governance of health coverage, insurance, and quality. They had the answer just this morning. It was a bid because we bid at an international level on competition, and we're going to create an institute of quality and social insurance. And that institute is going to be responsible of putting together all the other organizations for better healthcare, better quality, and to govern a bit the responsibility of each institution. They are responsible as well to evaluate, as we have here by the National Institute of Excellencies of Health
Innovation.
Services. Yes, thank you. They have to evaluate the medication that are going to be covered, the medical protocols, and other aspects of what can be covered by our government and our taxes, because in Quebec you have learned that we pay a lot of taxes to support our health system, our education system, and so on. Depending on what is our salary, we pay about 20-30% of taxes, which is
50% of that is going for
yeah.
healthcare.
Yes. So by health reform, we also realized a few projects in costing and pricing as well. And here in Quebec, as you know, it's pretty recent that we're doing that kind of follow-up of the cost. But in other countries, when they're starting to develop their health coverage, they need to know what is the real cost in every level of the health system. So primary care, hospital, and at the regional level, and a national and research center in university as well. So with some of our colleagues from Canada and other institutions, because we learn from each other, we were able to support, for example, in Ivory Coast, the pricing of all the health services by pathology and by what do you call this one? By case. Okay. And now they are at the point of review their pricing and what is going to be the contribution of the population, the private sector and the public sector as well. So it's there's many tools and many experiences around the world when we can get inspired and learn. So it's and I understand it's you're at that point too. Another aspect that we haven't talked about, and which I think in Quebec help the population to go to CLSC or primary care more, was the reform of the training of medical family doctors. So about 20 years ago, we reformed the way we trained our family doctors. And here in Quebec, which is different from other countries, the family doctor training program is a specialty. So they do 5 years, and after that they have 2 years of specialty. And I think that the quality of services will improve by that, and the trust of the population as well. And that, with other aspects of our healthcare system design, brought a bit more the population to the CLSCs and other institutions that we're going to visit. We also have the group of family doctors, which is a strategy to give a better access or service to the population. And I would say, as Dr. Brunet, the connectivity and artificial intelligence, it's pretty new, and there's a potential there to review the responsibility and sharing the responsibility of health and a better health among population and health organizations.
Vincent, tu vas partir dans 5 minutes. Peux-tu dire un petit bout de recherche de tes chercheurs sur les systèmes de soins?
Yeah, so we have the hospital, as Dr. Mounet said, has a research center that is part of the hospital. The beauty of a general hospital like ours, that is tertiary and quaternary, is that we have research stemming from basic science to clinical research to population health research with a very strong sector in population health, including some that are working on health systems. And if you're interested, I can certainly, because I think that relate a lot to the questions that you're addressing, I would be happy to, after the visit, introduce you to some of those folks who are really looking at the impact of the various healthcare reforms or organizations like academic health centers and or at the system level on the population. And to make that connection if you're interested.
Pas plus fort parce qu'on t'entend à peine là.
Sorry. Have you heard what I said, or do you
Not really.
to repeat? I'm saying that we have amongst the various scientists that are part of this hospital, we have people looking at the impact of healthcare reform and organization of academic health centers and of entire networks on the population, and I'd be happy to provide you those contacts and make sure that you can exchange with them directly after your visit. I guess the time now is a bit short, but we have a couple of people who are really well versed in that area.
And they got some funding from the organism, from the research organism, the federal and government.
Federal government, the provincial government.
The research is translated into health policy change very quickly, or
Not really,
Not quickly.
very quickly.
Not quickly.
Because, no, but you know, this is something that you will probably have the same in your country. We have a bureaucracy here and governmental orientation, so politicians and administrators. And we need to follow all the rules and laws and all the things which are taking time. So even if we have something which is very important, it takes time. Except if it's really mandatory to change it very rapidly, and I can get access to the minister at any time. But otherwise, it will take 2-3 years to be implemented. At this time, we have something new that is coming. So even if, but it's very difficult to demonstrate that something will dramatically improve the system, because the system is very complex. There is another last thing that I want to say before I'm leaving you, is I am the president of the RIS, which is the University of Montreal Integrated Healthcare Network. This is an interesting network of about 40% of all the healthcare organization of Quebec. And it's a large region, which is not only Montreal, but we have about 2.5 million inhabitants which are covered by this network. And this is a learning organization, so a learning network. And we use different data that we collect from the organization to improve the efficiency and performance of these different members of the network. Again, when we have some new way to deliver care or education or research, we can address the result to the minister and the ministry, and we can improve efficiency and performance of the system. However, it takes time. I just give you an example. 7 years ago, we have put in place a database analysis of cardiology for the myocardial infarction throughout the province. And we were recognized as an interesting method to improve performance and efficiency 7 years after. So that's okay. Eventually we have been recognized, but it took 7 years. When you look at the private organization in other countries, in less than 3 months, you will have the first results of analyzing all of this data. So see, it's really a huge delay between the result of what we are studying and the implementation. So that's not frustrating, that's Quebec. I'm sure. You know what? When countries that you should go and see is Senegal in Africa. Senegal, we have different communities and different networks into the world. And recently we had in Morocco a discussion about restructuring the different healthcare system. And there were 3 people, 2 a CEO and 1 from the Ministry of Senegal, who came and presented their restructuring. Extremely interesting. So if you have time, go to Senegal. And they will explain the way they are restructuring all the system, including the tertiary quaternary organization. The only thing is, when a CEO or when a medical doctor, because here it's like the cows in India, they are sacred. But there, in Senegal, if the physician was not performant, if the CEO was not performant, they will be thrown through the window. So I said, okay, that's a good point to make the people work. And they say we have completely decreased all the bureaucratic steps to get access to the treatment. But I said I will propose that in my country, in Quebec, but I'm not sure that I can throw the people out of the window.
We can't open the window.
We cannot. Show you. It's efficient. So I also have to leave. It's a pleasure. Enjoy your stay here in Quebec, in Montreal. And the other directors will explain further things. Especially Jean-Yves, you can speak about what is the framework for quality performance, which is an important thing of the counterpart, I would say, of the funding mechanism is the quality of care and the performance and efficiency. Enjoy your stay. It was a pleasure. Take yours, and whenever you want to connect, it would be a pleasure. Bye, and have a nice. Bye. Enjoy you too who arrived late.
I'm sorry.
No problem.
I
suggest you to send them
Welcome here, it's a pleasure.
there. So if you have any questions about this, you can reach out.
Oh, thank you. Oh, thank you. I will look at that. Thank you.
Yeah, that's for Senegal, one of the great countries which is reform recently.
For our province here, we have a few, a small visit in the hospital, but we can take some more time for more questions. Dr. Kassiaki will be visiting the hospital with us, so if you have questions concerning the management with the physicians in the hospital, will be on the way, be able to answer your questions. I don't know if you have any more questions concerning the budget and performance and cost and everything, because we have Richard here who is the specialist. If no more questions, to Jean-Yves Nguyen, who is responsible, maybe you can just explain your role and what we do.
Yes, actually,
And
we
from there.
cover a wide area that since we are transforming the CHUM within the last year, and as well as they explain about the whole global system of care in Quebec, we try more to implement the culture of measurement. So is it really important for us to know about the accessibility, about the satisfaction of the patient, and every outcomes as well, even of I'm talking about the adverse events and everything, complications. So what we are trying to do is try to capture the global dashboard of the establishment. I mean, at the whole level, we want to measure about the utilization of care services, the beds, the staffing, the cost related eventually. And we try always to focus on the patient accessibility, and when the episode is terminated, so we have to make sure about every quality is met. So when you go to see the hospital for a specific unit, we measure about the length of stay, and we benchmark them with the best practice in the whole world. So we try with the doctors to define the episode which should be the best one for the patient. And of course, it's a kind of we try to have the moyenne about this, but it's customized to each patient need after. But we try to keep the focus on the global stay of the patient as is the trajectory which is supposed to be. And we measure as well not only the length of stay, but what happens when the patient is in our hospital. So about the complication, the mortality rate, and after we try as well to get in touch with the other institution when we refer them, to make sure the current services that was provided here were the good one and were enough, and the patient was stable enough to be sent in another institution. That was referring to what you told before about the trajectory and the collaboration with the other establishment of the whole network from Quebec. So we're trying to collaborate with the other establishment to give us some feedbacks as well about the state of the patient we refer to them. So I've prepared in the presentation that Irene is going to send you some capture of the dashboard we have implemented here in the last year. We use that at a strategic level. The CEO uses it every day to know what is the state of the hospital when it comes in the morning. What about the ER? How many patients we have, for how long have they been there? How many of them have they came back after discharge? So, and we can see as well the reason why they come back within the 3, 5, 7 days. We measure all those things, and we can take a strategic decision about the change we have to do at a high level. What we're trying to do now is to go more specifically in the units, and we're trying to design the dashboard for every unit, what they want to see. As example, if you go in a unit of surgery, what are the indicators they have to follow to make sure the efficiency, the quality, the safety, and the best care are given there for the good patients. So that's we are trying to implement at that time. And if you have any question about this, I can show you eventually what are the we have a big balance scorecard, and then as well as the portal.
I have a question. I knew that. I understand that your system is basically global budget. So I think that it is the lower, the smaller patient. So you get how can I say, some profit or some profitable, so more making your hospital efficiently. So I wonder that what kind of your indicators, or maybe you can present one of what kind of indicators you have, such as kind of, I think that there can be two or three group of the indicators. That one is gonna be some kind of how can I say, shortening of the stays or something, just they make the lower patient in the hospital, and other things can be some outcome based, some kind of some cure rate or so as you say, the lower mortality rate or something. And that kind of indicates can be here that, and then if that kind of indicators are good, then you can get a more budget from the government or kind of any other reimbursement, better reimbursement from the RAMQ or something. I'm not sure that if
Actually,
there is
I think you're referring to the way we, I'm not sure about this, maybe Richard can explain more, is the difference we do between the primary, because we still have, actually, we treat about 30%, we try to go to 30% of tertiary and quaternary care, so we still have the primary and secondary one, so we have more, some patients that are lower, as you can say, which they cost less, but we still need to have those patients as well for the teaching mission and the research as well. But I don't know, Richard, if you can add.
Well, presently, we're not paid based on quality or
performance.
yeah, it's basically based on volume and complexity of cases. Meaning, if you look at the radiology or oncology, they look at the complexity of the cases and the price is based on that. So, but there's no pricing based on quality or outcomes, we're not there yet.
But we still have some indicators that help us to measure the how can I say, the weight of if the patients are more complex or not. It's a kind of complex mathematical formula that can link a level of complexity to the patient related to the disease, the level of care they need, and this helps as well to know how much does they cost at the end of it.
We have the system of DRGs.
DRG, yeah.
So we use that in the province. It's a kind of system which we took from the Maryland in the States. We adapted to Quebec. In some cases, they use it to evaluate the weight of the patients for each hospital and say, okay, how much you spend and how much you should spend, and then they make a difference. And they can adjust your global budget on that, saying, okay, if you're better, we'll give an incentive. If you're not, well, we'll apply pressure so you will be more efficient in your management.
I can say as well that was part of the big preparation we have to do before we moved, because the first step was to know what are the population of patients of each specialty. So we provide the doctors the mapping of the whole patients they have treated in the last year, and they have to think about what are those they should really be here, corresponding to the mission of the hospital, and which one should be redirected in the primary care. And they tried to make some reference of those patients that are really, really light and should have not been treated in the CHUM, in the first line services, saying that we still need that, as I told you, to keep some of them. It was on a voluntary base. But that exercise was done per specialty to make sure we have the right population of patients. The company talked about this earlier, but it's true that every patient can come to the ER and ask for services, but we still try to teach the population about the nature of service they need and the good way to respond to it, and they should know that as example, if they have a cold, they don't come to the CHUM, they go to see in first line the physician. in a private cabinet. So we try to teach the people about the mission of the hospital, so maybe they can understand that when it's not really complex, they shouldn't come here. And the doctor as well, they have to refer to their colleague in first league, and as we told, we have a lot of means as well to support the physician in first line that they can be supported and empowered.
Any kind of incentive about referring back to the primary physician from this hospital or not really? Yeah.
I don't know if you're aware, but doctors are not paid by the hospital.
Mm.
They're paid by the government
Yes.
essentially.
Mhm.
So we don't have total control over the doctors.
Oh, okay. You are.
Which is a good thing.
Well, our main challenges, I would say, as you mentioned, Jeanette, is to have the right patient at the right place. And this is what we're working on with the network to make sure that the population is well aware where they should go for what the problem they have. We usually say that if you don't need a specialist, it's maybe not the right person to see. It's more, a Thursday to see the right person who can take more care of you than the one, even though this is nice, this is the last technology hospital, it's maybe not here, then you need to, but if you need it, there it is there for everyone. This is the kind of campaign, this is where communication is involved in this, but we do work with physicians in the network because they work by reference as well. So sometimes the reference are made by, I know this specialist, and I know it will be okay with them, but we have to make sure that these reference are understood by the physician as well, that to refer the patient at the right place. Exactly. So I don't know if yes.
And just a quick clarification, because of the doctor's control by the hospital, yes, it's tricky, but because I heard that there's kind of some doctors reimbursed by kind of the fee for service based, even they are in their tunes, yeah. So is there any kind of it means that kind of can I understand the kind of salary or something, or just they do as much, they get as much as they do, kind of they about the surgery or something, because I heard that kind of DRG is kind of inpatient hospital care is totally covered by the budget from the government, and other things kind of something to what kind of activities done by the doctors can be covered from the government directly to the doctors, or so is there any kind of link between the hospital and doctors, kind of if doctors do something wrong in this hospital during their operation or surgery, if there's something happen or something goes wrong, the only doctors can have a responsibility about that patient or something, or kind of some.
No.
Yeah.
Actually,
Because
Well, in fact, there is a control mechanism which is called ECMDP, which is the gathering of all the physicians, and you have the privilege of working in the hospital. If you don't behave properly, you might lose those privileges, and if you try to go elsewhere because you did something wrong, you might have big problems. So that's why we can get some controls on how the doctors behave. And usually we don't have major problems, especially here. That's right, they all paid by TRAMQ, Régie d'assurance maladie du Québec, and they have an incentive of being very efficient, because if they have a given number of beds, if they want to make money, then those beds have to be turned around. A new patient is more pain than an old patient that stays too long. You understand that? So if they have a patient in the hospital for their first visit, let's say, they get $100. But for every other days, they might get only $20. So if those beds turn around faster, they make more money. That's an incentive of being efficient.
Because I understood, because it's global budget. As a doctor, maybe the new patient comes much more money, I understand. But as a hospitalization, the new patient spend
That's right.
more resources
Cost
from
more.
those
That's right.
customers.
Yeah, yeah.
So I think it is not, it's
It's
not
a
equal
tricky
for them.
balance.
Yeah, tricky
But
balance.
maybe
Richard told you that.
It may be counterproductive, but
Ah,
we're going there.
Yeah.
The day there will be the activity-based costing and the pricing will have to be more efficient. Otherwise, we'll lose money.
But I think the quality is an important indicator in that case, because if we discharge a patient too early because we want to turn the bed too fast, we will have some problem, because they will
Yeah.
come back and
Yeah.
they will cost more at the end of it. So we will be penalized otherwise.
That's a professional control.
I think that is kind of tricky balance between
Yeah, yeah,
two.
absolutely.
Yeah.
Absolutely.
Doctors,
Good job.
usually doctors.
Yeah, yeah.
It's not explicit way, it's an implicit way of balancing.
Yeah, yeah, yeah.
Exactly. Because we know that the patient who comes back after 7 days because of infection or things like that, it costs twice as much. I mean,
Yeah.
it's very.
And we can measure his feedback.
Mm.
It's the same patient that has been back.
Try to,
And we can be penalized.
try to cut 1 day, make kind of 10 days cost more if we fail to make the quality. So that's the balance, intrinsic balance. Then let me ask a bit more about the family medicine group's impact, even in official statistics not here yet. However, after having that family medicine grouping kind of covers more than 80% of the population now, so that if everybody says it's improving, even though it's still going on, then if that improvement may officially getting more access from the patient perspective, then now I'm asking that